Ara, thank you for accepting this invitation to join ASA for the series of lectures. Under the circumstances, we would have loved to have you at the Iran Eye Surah, obviously, but the circumstances dictate otherwise to host it the way we're hosting it these days. So a little bit about the presentation. Whoops. Okay, here. Strabismus, if I'm saying it correctly, Ara,
Yes.
is an ocular condition that occurs due to an imbalance in ocular muscle tensions. It interferes with the development of binocular vision and may lead to amblyopia. Okay, this is a common thing between children, both in children and adults. I won't go too much into it, but let me tell you a little bit about Dr. Keshishian himself. Ara Keshishian started his education in Glendale Community College. He graduated from USC with a degree in biomedical engineering. He then went to medical school at the American University of Caribbean. He completed his surgical residency in Michigan. He's a board certified general surgeon by the American Board of Surgery and a fellow of the American Society of Metabolic and Bariatric Surgery. Through his entire educational and professional careers, he has done research and published in medical and biomedical engineering fields. These have all been directed at new technologies to improve medical diagnosis and treatment modalities for patients. He is married with twin boys, 14 years old. PinPointEyes, a personal and passion project, was developed to standardize diagnosis of a certain eye condition and significantly expand and improve therapeutic options for those afflicted with the certain eye condition. Again, thank you, Ara, and please, you have the floor. Or the waves.
Thank you very much, everyone. First of all, I want to apologize for the delay. Sona and Linda were kind enough that a few days ago we did do a dry run on this and it worked perfectly till we set this up today and it started misfiring. And I also want to thank Rosmik and Richard here in a sec for giving me the opportunity and inviting me to talk about my work and experience that I've had. So we're going to talk about strabismus, and there's a few conditions related to that. This is talking to smart engineers. I had to sort of navigate how am I going to say something that sounds intelligent. This talk is going to be encompassing a component of sort of setting up the foundation for a medical understanding. There's going to be some treatment modalities we're going to talk about, and there's going to be an engineering stuff that we're going to talk about last. There's going to be the third and a third and a third. So from a disclaimer point of view, I'm the developer of the technology. This is not a solicitation of any sort. Oops, sorry, I just scanned through it. Just as a sort of a public service announcement, let's keep the physical distancing going. We see a lot of things on the medical side that it's important. Let's be safe, and we'll get over this together. So as for the outline is concerned, I'm going to talk about the strabismus. We're going to define the problems that we're trying to address, the problems that need to be addressed come into multiple forms. We're going to talk about the problems with the diagnostic modalities and also the problem with the treatment options that exist. And we're going to define each one of them, and when we were faced with those challenges, how did we come about addressing them? And for this narrative to make sense, for the storyline to make sense, I really want to sort of put this into the order that, as Rodney graciously introduced me, I was an engineer first, became a surgeon, and became a father. And as I talk about this, without even pointing this out, you'll appreciate how things evolved. So let's just jump right into it. There's, I think, 4 things that we need to sort of have a better understanding of. There's not going to be a medical test after this. I realize 7:30, everyone has got other things to do. Maybe we should have a glass of wine, everyone. Amblyopia, which is that sort of underlined, is a visual disturbance. So if we think about any condition that prevents me from seeing from both of my eyes. That will result in amblyopia. And that's when one of the eyes leading to decreased binocular vision. So if both of my eyes are not seeing things that completely overlap, then for whatever reason or whatever mechanism, the brain is going to ignore one of the signals at the brain level. Strabismus is what can lead to amblyopia, and we're going to talk specifically about this. Strabismus is when the eyes are not directed in the same direction. So my eyes are supposed to be pointing in the same direction with about a 10-15 centimeter distance. But if for whatever reasons one of my eye is deviated, then I have strabismus, and strabismus can lead to amblyopia because the image that goes from the left eye and the right eye to the brain do not overlap. This is gross oversimplification of the fact. This is not a medical lecture, and I'm not an eye specialist, ironically. So we could have talked a lot in further depth about conditions that look like strabismus, but they're not because of the way our anatomy sets a certain eye. Some of us have a point in our retina that receives the most intensity of the light that's a little off center, and on and on. So amblyopia is when the eyes do not see things in a parallel format. Strabismus when the muscles don't line up, and the end result is one of a couple of things. One of them is binocular vision that's lost. And binocular vision is, for the easiest way to explain, would be superimposed images that come from two different angles that match and that gave us the depth perception. The measurement for where the eyes are located in reference to each other is by prism diopter test, and we'll talk about every single one of these here shortly. Amblyopia, as we described, is a visual disturbance. So if you look at the left image, and as I said, amblyopia can be caused by a number of things. One of them is by strabismus, which is when the eyes don't line up. The image on the left, you can see that the image of the cat is crispy clear, and it transmits the information to the brain. Brain sees that. The one from the right eye, for whatever reason in this case, is not crisp. And since those images don't superimpose precisely, the brain ignores the signals from one of the eyes. So this patient has single vision going from one of the sides. The way ordinarily amblyopia is treated with children is we patch the good eye to force the deviated eye to point to the intended site to take that signal to the brain. Again, amblyopia can be caused by other reasons, such as neurovascular, nerve injury, and in this case, maybe the strabismus we're going to talk about. Strabismus is misalignment of the eye. It can result in two primary issues: loss of the peripheral vision and loss of the depth perception. Those cartoons on the left essentially are outlined. Left and right really doesn't matter. An eye is considered a principal direction, and the secondary eye, whichever may be inward, eso, exo, hyper, or hypo in relation to different angles to the to determinant eye. Interestingly speaking, in children, you see where they may have intermint, where one eye may deviate at certain times, and then the other eye may be the predominant eye, and the opposite eye will deviate. So you may have a patient that actually out-deviates on one side, on the left eye, and certain times the left eye is straight and the right deviates to the inner side, in which case usually most of the patients need surgical treatment of both of the eyes, essentially. Over time, if the eyes are misaligned, the brain gets confusing signals and ignores one of the information from the deviated eye, and that essentially leads into loss of depth perception and peripheral vision. When I do this presentation in person, I actually have a test, and you can try to sort of see from a fixed item across the room by about 4 to 5 feet. Keep your nose straight at it, And then if you can blink your eye relatively quickly, if not, try to move your hand across, you'll see that even though when you're not moving your head, the object seems to be moving left to right. What you're experiencing is the change in the angle from your perception, and that lack of overlap is what leads to loss of depth perception. Uh, as far as the peripheral vision is concerned, pretty simple test. You know, my nose and my eye from here essentially sees about 180 degrees all the way to midline. If you sort of hold your arms out and you try to look at something, you'll see that I'm going to have to come to about 60 degrees before I start seeing my left arm because my left arm was closed. So that leads into loss of peripheral vision. And as I'm sure you'll all appreciate, those are things that could potentially have detrimental lifelong results for someone's ability to do certain things in life. Strabismus is not a neurovascular problem per se. So as soon as the signal hits the retina, everything all the way going from the retina through the chiasm all the way to the occipital lobe, the signals are transmitted all the way to the brain. The reason why those neural pathways go through perceptive atrophy, sort of the use it or lose it type of a concept, is that because the images are not overlapping, it causes a confusion at the perceptive level at the brain. And brain says, well, if I'm looking at this monitor, why are you showing me that picture? Ignore the image from the picture. So the nerve pathway from the deviated eye over long term goes away. And there's been literature that have talked about over time, vision therapy will bring it back. The key with this is to prevent this from happening long term. Again, this is a muscle alignment problem at the level of the muscles that control the movement of the eye rather than a neurovascular issue. Binocular is sort of the concept of depth perception. This cartoon shows if you're looking at the row on the left-hand side, you see it from a certain angle. If you look at the same thing with the right eye, you're seeing a different angle. When the brain puts those two images together, it shows a depth perception over time. And we need to appreciate that over time in children who don't have that, the neuroplasticity will go away and they'll essentially lose peripheral vision and the depth perception. I won't. There's an object to this. I think Sona and I talked about this. So we're going to put this thing on the website. This information on our website would be accessible to people. There's images of dinosaur in this. I don't know if anyone can see it or not, but those of you that are on the phone may be hard to appreciate. Pressing the right button. So we're just going to sort of shift gear and talk about specific about strabismus, short segment, and then we'll talk about the engineering aspect of this. So strabismus, as we talked about, is essentially when the eyes are not aligned in the same direction, and that leads to amblyopia, which is loss of vision. We see this in about 5% of the children. Commonly, it's known as lazy eye or crossed eye. The true incidence of strabismus in adults is unknown because strabismus can be caused by a number of different variables in adults. Traumatic head injury in a form of military blast injury survivors, for example, football player, professional sports, boxers who get hit in the head, with nerve palsies. All of those things can cause misalignment of the eye in adults, and it's much harder to address those than in the children. Children over time, as they start learning to walk and function, if they have loss of vision perceptively from one eye, will accommodate for everything else. Whereas adults, we're all used to doing certain things. Next thing you know, we're tripping over each other or bumping into a door or wall because we've lost of depth perception. Loss of depth perception is a neural pathway problem, and that results to perceptive atrophy, as we talked about. And the key with this for children is early diagnosis and treatment. Literature in the ophthalmology field is sort of goes over a range. There are people talking about in a matter of years and years where, 10 to 12 years old is where you sort of should have everything buttoned down for things not to really deteriorate much further long term. The treatment option for strabismus from sort of simpler to more complex would be, and we'll talk about this again further down the road, would be glasses to correct the optical issues. So if a patient is deviating because of the shape of the eye, it's not, the lens is not in a way which corresponds to one side versus the other, and it's more of an elliptical, then the eye may have to rotate in a certain way to keep the image focused on the retina. That will result in an axis rotation and or misalignment of the eye. So there's some patients that actually benefit by just correcting the optically the alignment of the eye. The second issue becomes then, if that's not the case, how do you address them? Then you see those eye patches that are placed, and we'll talk about that briefly here. Vision therapy, think of this as a physical therapy for my knee that I twisted a few weeks ago, and I have to have a physical therapy for my knee. You sort of do similar exercises with the eyes. We have ropes and balls at certain depth, and you have to tie it on a doorknob and have the child look at it from a certain angle, trying to pull that eye muscle left and right, then look at it from the other side, try to pull it from the other side. And essentially, it's a matter of exercising the eyes back and forth. Very effective, but try to have a 5-year-old kid stand still for 2 minutes and have them look at a ball, a small bead on a long string, and try to tell you where it is. Surgical intervention is when surgeons go in and essentially cut the muscles off the eye and then bring the eye in the proper place and suture the eyes, the muscles to the eyes in what they to them at the time is straight. As I'm sure you'll appreciate, this has a relatively high failure rate, which is mostly due to the growth rate and the fact that we're talking about placing a muscle 1 millimeter back and forth, and that may be very hard to do in a natural healthy tissue, which, just the tissue elasticity may offset whether I put something 1 centimeter further or not. Botox, as you know, for sort of wrinkles and things like that, works by paralyzing the muscles. And the concept is that if some patients require Botox injection into the eye muscles to essentially relax the muscle, as expected with any Botox injection, a temporary solution, really doesn't do much. And we'll talk about that briefly. There is supposed to be a what I'm going to do is I'm going to see if I can do it this way for a sec. So that was essentially a summary of where we're going to go to the third part of this. The presentation is how do we diagnose the deviation accurately, and what do we do with these? We briefly talked about the prism diopter concept, and some of you may have seen these when you had your eye exam. The angle of deviation is by unit of prism diopter, and the prism diopter is the deviation in centimeter over of a light deviation 1 meter out in centimeter to the angle of the prism. So a 15 degrees prism will drop the light by 15 centimeter a meter out. So, and this is, you can see this, and there's sort of a prism numbers, 45, 40, 30, and 35, and all that. As engineers, I always found it fascinating that when we would go to the ophthalmologist's office, we would be given a relative guesstimation that, well, I think the deviation is between 25 to 30, which is, you know, five centimeter distance in deviation over a meter, which, you know, it's miles and miles in the scheme of things. And yet the precision level in the operating room is millimeters, which to me, I could never reconcile. How can we take a measurement with a ruler that's off by 5 centimeter and try to design a machine that the tolerances are in millimeters? I just couldn't add up to it. That became evident that the measurement of the prism diopter is extremely experience dependent. There are issues with reproducibility of the data, both to time and person, where same patient examined by 2 or 3 clinicians, you will get 3 different numbers. Same image or same styrofoam head with a deviated eye measured by the same person, you will get different results different times. The other problem is that there is the prism diopter, as you can imagine from the physics of it, is not a linear connection. As you get past 45 degrees to 90 degrees, if the light shines 90 degrees, it goes to infinity. So that one-to-one correlation between what the physician measures in the office and try to translate into the operating room may be linear. Once you get to a higher deviation, it sort of ends up being a little of a guesswork. So the first challenge was to how do we devise a technology to be able to do the diagnostic measurements accurately, where it needs to minimize the error. It is critical in not only for planning the surgery, but also it'd be important to know if there's a really quick way to validate the efficacy of the treatment that I, as a parent, and working with my child. So put the patch on and come back to see me in 6 weeks time. Let's see how things are going. Well, a lot of things happen in 6 weeks time, especially when a child is growing fast. So is there a way for us to be able to quantify whether the treatment is working or not? And also, am I seeing one physician or I'm seeing their partner? I think there has to be a way to sort of quantify and validate the data by doing it repetitively by the same person. The app that we developed essentially has multiple modalities. There's multiple pictures. Essentially, this is the outcome of the picture, where someone who's doing their own treatment, or they're patching their eye, or they're doing vision exercises, they can take a picture with inward looking, or the caregiver or whoever family member can take a picture with the outer looking camera. The camera, it's an AI based. This is one of the earlier images. So it measures the distance, finds the pupils, finds the irises, and essentially spits out all of the information that's needed, which eye is deviated, what the distance was, the picture that was taken, what the angle of deviation was, what the actual distance of the deviation was, and what the deviation was in the X and Y axis in a form of millimeter from the baseline. So this becomes documented, and there's an objective way to look at this without really having to worry about who did the examination, who didn't do examination. From an app point of view, this thing is stored into the patient's medical chart, and it can be looked at later on. This was the subject of what we ran as an IRB sanctioned study at Harvard Medical School about 2 years ago, We validated our data that essentially the fellow, the attending, the fellow, and the app essentially all matched. It was very interesting because there was significant deviation between the and app, uh, fellows and app and the attending at the larger angle. And you can see there was a drop in this. I think this correlates as to because the app is actually sort of a mathematical model of the orbit moving into 3 dimension and what the axis does in a form of vector, it maintains tolerances independent of the curve, whereas visually when you're doing it with the prism diopter, it becomes really challenging for someone who doesn't have the experience. As they're getting to a larger and larger prism diopter, end up getting more and more deviation. So there was a little the separation of the data where our data match what the attending is considered gold standard. From an engineering point of view, I would challenge to say that actually our data should be considered a gold standard because we can validate where we can take a sphere, put known positions with known angles, take pictures of them, and that becomes the valid data versus a clinician may be taking based on their experience what their numbers are going to be. So now that we know exactly what the eyes are doing and what the angles of the deviation are based on prism diopter, let's move on. How do we solve our problem? And just looking at that briefly that I talked about. So one of the issues is patching, then corrective glasses for lenses. Some children have to put lenses for near and far sightedness with some prism component to it. Surgery to surgically correct essentially disconnect the muscles, move the eyeballs in the right place, and suture them back on again. For some limited use or some children that will get Botox injection, atropine is essentially a dilator of the pupil, which essentially makes you not want to look at and essentially blinds you because there's so much light going in. So it's a chemical way to patch the eye. And unfortunately, there's literature out of Germany for years that have come up that 50% of the children that have surgical treatment for strabismus early on will have to have second and sometimes even a third operation. When I was putting this, adding some pictures for this lecture some time ago, it's interesting when you're looking at the internet, there's a whole bunch of pictures of children who are smiling, putting the eye patch on. I'm not sure how real that is, but the idea of putting the patch is to cover the non-deviated eye to force the muscles of the deviated eye overwork in the intended direction of the gaze. So if I'm looking straight and my left eye is out, you want to cover the right eye to force the left eye to come in by forcing the muscles to bring the eye into the field. So this can, as I'm sure you appreciate, there's a whole bunch of immediate question that as engineers come to your mind would be, well, what happens to the good eye? That's number one. So if I keep blocking this and I don't use this, am I going to do something to my the deviator eye that comes in? What's going to happen to my good eyes? It's just the muscle's going to get worse and worse and worse. And what happens to the muscle atrophy? That's why the recommendations are from optometrists and ophthalmologists that this should be, literature is all over it, between 2-hour patching to 6-hour patching, do short segment patching, do multiple short segment patching versus long segment patching. As with so many things in nowadays, you can find the literature that supports one side or the other side of the argument either way. From a parent, I can tell you it's not an easy task to put an eye patch on a 4-year-old kid and say, go to the backyard and go have fun, and then in about 20 minutes that thing is off, and on and on and on. So how do we leverage the existing technology with everything that we do to do that? This is what we used to deal with every time we talk about eye patching, not that happy kid on the previous slide. The technology that we use is based on a liquid crystal lenses. There's 2 versions of the glasses, and I'll briefly talk about one of them. It's a passive device. It essentially, the glasses are placed, and I have one of the versions of them, and they essentially go into a self-testing cycle. You turn them on, make sure everything connectivity is correct and everything's working well. It pairs up with a Bluetooth into a pair of sort of the host mothership, if you would, the parent's iPhone. Calibration information are sent into the glasses. So let's say the optometrist says we want to have 5 minutes on, 2 minutes off, 5 minutes on, 2 minutes on, with the deviated or non-deviated. That code is pushed into the glasses. The child put the glasses on, turns it on, and right now, obviously for legal and safety issues, you really don't want the kid to put this on and go biking on the street. This would be a limited activity, watching TV, playing video game, reading a book, maybe walking in the backyard, but it's really not something you put on and go play basketball for a little while. And again, this is taking the concept of eye patching and making it really practical and non-intrusive, especially that you can actually put optical glasses on this to make this work for those children like this picture, not only needs the eye patch, but also needs to wear glasses on. So the second phase, the second type of the glasses would be to try to take the sort of the first version of the glasses that are receiving they're coded and receive the instruction from the mothership, to have intelligent technology built into them for them to be able to identify where the glasses are, where the eyes are located. Based on that information, run through the AI, make a certain amount of decisions, and then process how to take what actions to take. So, okay, I guess I have to do this one more time. These have embedded videos. I apologize, they're not showing them, so I have to do it this way. I have to go back and forth. So this is essentially the very first prototype that was built. Liquid crystals, simple Arduino boards, oscillating at a certain way. We had to essentially convert, the DC to AC current. And this is the very first prototype that was built. As far as the glasses, a 9-volt battery, it's off-the-shelf Arduino board, some coding that was reverse engineered from a whole bunch of Sony 3D glasses and Panasonic, and they're very dark. They're not there anymore because we had to, figure out how to have the polarities work, things that I had to learn as I was going along. And I'm gonna have to go back and forth here on this a couple of times. And then, so as we talked about, we're going to take this concept of the glasses, how do we analyze them, and what do we do with the information of the position of the eye? Many years ago, I was lucky enough to cross paths with Richard, Richard and I have a mutual friend through JPL who introduced me to Richard, and he helped me early on with the development of the part of this project. And we started early on by what we thought would be the easiest thing logically to do, which was to mount inward-looking cameras at the frame of the glass. And so essentially look inward to the glasses, identify where the pupils are, continue monitoring them where they are, and compare the left and right data continuously. And then when one of the position data was off from the mirror image of the other side, then you would call that as an action and then take an action from it. Pretty straightforward, and we worked it all. We carried on for a little while. We actually ended up taking 1 or 2 different prototypes built. Became very obvious early on that the amount of data that was coming in was very heavy consumptive on the power and computation for it to be valuable, because we were essentially getting continuous stream of data. Even with Richard at the time we're talking about, and we did sort of dumb down the information. We didn't need to have high quality images and on, but it became overwhelming to the system to a point where you needed a car battery and a Mac to run around with the glasses to essentially analyze that data and do what we really needed to do. So after giving it much thought, we sort of said we can go back and start taking limited data, 1 picture at a time. And this is what, after about a year or so working and putzing around with inward-looking cameras, we essentially created we create a pixelated image of the eye from different angles. Instead of having a single camera collect that data and parse it on the processor, we decided to mount a number of RGB sensors on different places of the glasses, and we had, all four corners, and then we put a whole bunch of them on the bottom. We did some on the sides, and then eventually came up what we think is an optimal situation where we're collecting a set of data from different sensors. And what we eventually ended up doing was we came out with what we term in our patent as the color signature of the eye. So if in the most simplest way, this is an extremely low resolution pixelated image of the eye from different angles superimposed on the back end in the processor versus being captured individually as a single camera and going in. So a straight gaze in the, and we did all of this in a tested format where the these LEDs were positioned in the styrofoam head in known position. So we could predict, we knew exactly where each LED was located. So in a straight gaze, the top, left, right, and bottom LEDs would, the sensors on the glasses would all have a different profile. The up gaze would have a different profile, the right gaze, left gaze, and the down gaze. So we were able to have a predictable model where the sensors would have a certain color signature profile based on the gaze position. Now, immediately we would think about, well, what if I walked outside? What if I had a light on? What if I tilted my head? I just want to go back and remind ourselves that the purpose of this exercise was not to find where each eye is located precisely, but whether there was a change in the position of the eye compared to the opposite side. So all we were trying to do was to compare a set of data where we can compare left to the right and see if there is any certain threshold of difference that's met. And if let's say these random numbers for a right eye looking at the right direction is significantly dissimilar from the left side, then that would mean that one of the eyes is deviated, and that becomes part of the algorithm. The way that decision would be made would be very intuitive, that when I'm looking straight, my head is in a certain position, but when I want to turn right, I would never hold my head to the right and always look with my left eye straight this way. The tendency would be to turn to the direction of the gaze. So at extreme angles, those color signatures may not match, but we would offset that by giving a longer time latency, not triggering the algorithm, but rather letting the information to settle down to a maintained deviated angle before we would take an action. So now that we have this set of collected data coming in from 4 sensors on the left and right, and we eventually settled, I don't know if I can show this, but there's 4 sensors at the bottom of the glasses, each side. And so each one of them sends a different set of information for 4 colors and luminosity, and that's what you see on the graphs here. We went from the LEDs into setting up an experiment with glass eyes. It's hard to tell, but these all have holes in them, in a predetermined, drilled holes in them in predetermined angles. So we know precisely where the eyes are located, where the deviation are located. They're wired on the back end to LEDs, where they would randomly fire. And then we would be able to, with our glasses, take actions on them as to are they deviated enough, and code the AI to make the opacification occur or not. This is the picture of the first test bed that we created with the 4 sensors on one side, the Nordic chip for the Bluetooth and the power regulator all inclusive. This was just to test our PCB technology. Going up to sort of final product, as you can see, This essentially is the 4 sensors on one side, 4 sensors the other side. The other chip that the complete board that's placed is we're about 2 generations further past this already. We have nearly completely embedded all of the cables. All of these hardware that are set up here for connection are all removed. And essentially, the glasses have sensors in them that measure any significant changes from left to right. If those deviation between one side to the other side based on our still to improved algorithm takes an action, we decide whether the lens needs to be occluded or not. The variables that we're working on is how long the deviation is, time frame. So we don't want to take action because then every time you blink your eyes, you're going to trigger these lenses to opacify on and off. The other thing would be for example, what if a child's eye deviates for a minute or so and then comes back? Should we take an action or not? And those are different things that we're testing right now. I have an older test run. And so each sensor, this is significantly slowed down. There are 8 sensors, 4 variables. We're taking 10 readings per second. We had to write our own code for testing the glasses. As you can see, as one of the lenses are opacified, each, this is the left and the right, each one of them has 4 channels, red, green, blue, and luminosity, and we can selectively on each one of the sensors, we can block off any one of the sensors that we want. And you can see as each one of the sensors is blocked, there's a certain characteristically change that takes place, and these changes are what will trigger the action on the lens. So if you have significant deviation between the left and right, that deviation is sensed, that will cause the lens to opacify, electronically patching the patient's eye. All of this data is collected. So just like a heart monitor, when a cardiologist may send you in and say, put this patch on, it's a heart monitor, essentially like a Holter monitor, and we look at things, information later on. The same thing can happen with this, where this information is all stored, the deviation are all stored into the chip. When the glasses are paired with the sort of the mothership iPhone again, or the iPad, the data is collected and is pushed to the ophthalmologist or the optometrist. So they're able to look at it and see how the progression, how long are the deviation, both the angle of the deviation and whether they're, how long they're staying there and how far they're staying there. I want to also I don't know if I can show this to you, but those of you that may be looking at the camera, you can see how it's oscillating back and forth, and it's essentially sensing the ambient, the color. It's essentially taking the color signature as a baseline, and it's on right now. And then as the sensors start changing, it's going to start taking the function of opacifying as the deviation takes place. So what's next for us? We are in collaboration with Children's Hospitals of LA. We have a number of studies that are in different stages, both here, Fullerton, College of Optometry in Oregon, and I've been in contact with Armenia Eye Project. Those of you may or may not know them. I've been to a couple of trips to Armenia recently before this COVID virus, and we're essentially going to be deploying the app as a screening tool through the Health Ministry and the Department of Education to screen all of the children in 6 to 11 years old. as a part of their screening project, and that's going to be a massive amount of data for us to be able to utilize in our UI for our AI for further development of the algorithm as to sense things like different eye colors have a different deviation, sense the thresholds for that to be triggered. So I would like to thank everyone for listening to this. Once again, Sona, Linda, Rosmik, and Richard, thank you for your help. And I'll take any questions that you may have. And sorry for being late a little earlier.
Thank you.
Well, yeah.
Oh, go ahead, Rosmik.
No, I was just going to say thank you, Ara. It was very informative. I have one question, and then again we'll open up the forum to everyone else. Obviously, my question is this: when at the very beginning, when you stated the bad eye, let's say you have a good eye, which good signals go to the brain, and then there is the bad eye that sends signals, and the brain selects which ones to accept, and the image is then obviously seen. Now, does that mean if this other set of signals from the other eye, the not so good eye, is ignored, if I cover the good eye, will I be able to see it? Will I be able to see, or not? I won't be able to see. You know, I guess I'm trying to understand when you say the brain ignores it. What does that mean? Ignores it.
So, so if you there's essentially three distinct phases that happens to where my eyes are directed to and what I think I'm seeing. So one of them is just simple physics of light hitting the retina, causing thresholds, electrons are released, and that causes an action potential, and a current is sent. That signal, through a whole modulation, has color, shape, and all that encoded to it. That goes to a center where a first set of perception takes place. So, and it's associated with, is this what I'm looking at? Is this what I think I should be looking at? So, and that's sort of the, if you would, a simple CPU of, okay, you're driving straight, look there type of a thing. Then based on that information that goes to the occipital lobe, and that's the visual cortex, that's where the information, okay, what you're pointing to and what information is coming in is what I really want to see. Those two images at that occipital cortex at the back of the brain need to completely overlap. Well, not completely, just a little offset to give the 3D image. So if I understand your question, if I want to consciously look straight, my eye is looking straight on the right. The central processor says, yes, Ara, keep looking straight because that's what you want. But the left eye is sending a signal from the door. So the right side of the brain says, monitor, monitor, monitor. The left eye says, monitor, door, door. I don't want to look at that. This is no good. I'm going to ignore this signal because those images don't overlap each other. And so the phases of the vision that fails with strabismus is not the action potential, is not the generation of the electrical current from the eyeball to the first perceptive phase. It's from there. The brain doesn't know what to do with this. If I'm talking to you and I want to see your face, why am I seeing an image of the door? I don't want that. Close that, shut that information so I don't see it. And if that goes on over time, that part of the brain, those conduits end up going through atrophy. So the way to prevent that from rusting, if you would be to close my non-deviated eye. Now that I want to see you, now I want to look at you because I can see, I'm forced to bring my eye inward.
Yeah, okay. Okay, yeah.
Do I understand the question correctly?
Yes, the issue was the back and how the signals from the back to the brain are processed. That's yes. Where I was confused. Now I'm okay.
Right. Okay.
All right. I have a quick question before we go into one of the questions that we got asked. My question is, so this protocol, if the person is an adult and that person had it since she was a kid, is it still able to like correct it, or like is it at a late stage and something else has to be done? Like,
Uh, so no, we actually our Harvard study, because of legal and IRB issues, was all run on adults, believe it or not, even though this project for me started for my son and it was a passion project. When we paired up with Harvard, sort of running a test on children was out of question. So we essentially ran a test on adults, and we have a testimonial on one of our patients, one of our very first patient, formal official patient, is a gentleman with traumatic head injury from military who, I want to sort of see if I can do it this way. Where you can see these are before and after treatment. This is before he would wear the glass. He would take a picture of himself. You can see visually how deviated it is. Then later on, he would wear the glasses for half an hour, and an hour later take the glasses. You can see how just the deviation is back in, out, in, out, in, and so he kept doing this for months and months and months. And the first time that I saw this gentleman, as a his wife was a patient of mine in my office for a surgical problem, and after we talked to him, I said, "No, you know, your eyes. Can I talk about this?" So we paired up. He started wearing our glasses and using the app to measure it, and now he drives where he couldn't drive. Something that caught really my eye was he has to stop driving because he said he used to drive in the road and suddenly he would see the guardrail, what he would think the guardrail would come into the road. For whatever reason, even though his eye was deviated, every so often he would get this sporadic image that would come into his perception that, oh, there's a guardrail, and he just stopped driving because he couldn't navigate. So I would say right now, half of the people that are wearing these glasses that would sort of give it out to them, they're all adults, and the rest are children. I should also say that we talked about the causes of the strabismus in adults is different. Certain, someone that has had significant stroke and they have double vision because of the stroke, that may be very hard to correct. Traumatic brain injury may be easier to deal with because that may be a localized issue per se. Some nerve palsies are also issues that may or may not be correctable early on. But right now, our position, again, we're going through the FDA steps, but right now our position is that these are things that can be addressed.
Okay, yeah, my question was for like someone, let's say, had it since childhood, like if that was correctable or some other. It depends, I guess, like on the research.
So yes, so it is. I'm only saying that because there is enough literature out there that talks about the standard vision therapy modalities have been shown to significantly help with the alignment in children that have had, in adults who have untreated strabismus from childhood. That's because purely a neuromuscular issue that needs to be corrected. So the analogy would be if I had a bad contracture of an elbow that was never corrected, I may be able to get some range of motion by playing with it. That's different than if I had full range of motion and broke it. So it is possible to do that, yes.
Okay. So another question I have is from a student who's currently doing an ophthalmology research in biomedical engineering lab, and she wants to transition into medicine. And she's wondering, she's wondering what's your experience going to Caribbean and then getting residency and going into ophthalmology?
Probably not very likely. Ophthalmology is one of the very hardest fellowships to get into, along along others, even though this comes and goes. I got into surgical residency program during a very difficult time too. So, you can share my information with them and we can talk about it if you want privately. I'm not sure there's anything for the group, but it's doable. I would just not, if that's what you wanted, you probably want to go to a recognized US school.
I heard, yeah, like I've had people who gone to Caribbean and it takes a longer time for them to get the residency or the licensing here in United States, like versus to someone who's studying in United States within the premises, I guess.
Well, I guess different people may have different experiences. I went through the 2 years of, I did my first 2 years in medical school in Caribbean, then took my US Assembly Boards Part 1, went to Michigan. I was in Detroit for 7 years. These are the last 2 years and 5 years of residency, still as a Caribbean student. I think the surgical training and actually residency training wins and waxes in the US. When I was starting medical school, everyone wanted to be primary care. So you couldn't get a primary care residency if you gave a kidney. Then when I finished my medical school, I really wanted to go to surgery. Everyone had shifted to surgical residencies and subspecialties, so it was very competitive. In general, there are certain things that even within US standards, they're very competitive to get into. Ophthalmology is one of them, dermatology is one of them. If you look at the number of positions that are available within the pool of them, they're very little. I've been out of this for 20 years, so I'm not sure what the numbers are, but from what I hear, they're still sort of pretty much the same. Don't give up on your dream, though. I keep reminding people that no one has ever asked me where I went to medical school. All they want to know is you take the same USMLE exam, you take the same board certification exam. I have to every 10 years take my board certification exam, and no one really cares.
That's kind of like I guess in civil engineering is after you finish your school, it doesn't matter what school you go to, as long as you're done, and then they hire you. So I guess
Right, true. And the only thing is that, for example, at least in surgery, we have to go through recertification exam every 10 years. And now they've changed the model of it. We have to do it every 3 years because every 10 years was too long of a test and too far away. Now they're doing shorter tests every 3 years. So every 3 years, we have to take a certain set of tests to pass. So you're at least fairly sure that the surgeon that's operating on you has a knowledge base that's no older than 3 years, hopefully.
Okay, that's a great information. Another question I have is, where do you see the greatest opportunity for pinpoint technology, diagnostic or therapeutic, and where is the greatest challenge?
So we think that there is in developing versus developed countries, there are sort of two different challenges. Screening, early intervention is the key to avoid lifelong disability. So in places like Armenia, I think there's a great opportunity for early screening, which is why we try to pair with the Armenia Eye Project. And essentially the app is for free. It's going to be deployed there for free. We don't want anything, just get the test done and pick the children that need help. That's sort of where that thing is. So I think there's an opportunity in environments like that. In the US, interestingly enough, similar things happen is because unless you are in LA and you have access to places like Huntington and Cedars and UCLA, there are not a lot of pediatric ophthalmologists around in middle of Kansas to be able to see children. So there's an opportunity for that as well too. So that's from a public health perspective. From a mechanical therapeutic perspective, I do think there is a great potential for PinPointEyes, the therapeutic device. That's because if you look at the cost of vision therapy, surgery, repeated Botox injection, and on, it really becomes cost prohibitive for a lot of children to get the care they want. Whereas what we're proposing would be a relatively inexpensive pair of glasses that you can probably break it every year and get another one, and it's probably still going to be a lot cheaper than the iPhone that most children have. So from a lifelong benefit point of view, we think they're going to serve two purposes. Clearly, they're, you know, a glass, someone that has the glasses is going to have the app too, so that they can monitor how they're getting better or not. But for rest of the population that may not want or cannot have the glasses, I think early diagnosis will be critical too.
Forgot I muted myself. That's a great information. Another question came is any research for vision impaired people?
I'm sorry, you're breaking up. One more time?
Oh, can you hear me well?
Yeah, it seems like there's a little delay.
Okay. Any
I
research,
can hear you now. Okay.
any research for vision impaired people?
So, you know, when we were doing the study at Harvard, they were doing a lot of work on artificial retina and things like that. I mean, there's very little that will overlap with the work that we're doing. Ours is mostly early diagnosis for that unique condition, and how do we exercise the eyes in a predictable way to prevent from something going back. So I'm not sure how much overlap may be on top of this, but there's a lot of research going on um, all over the world and the US with regards to artificial vision. Some of the key technology is it's in tissue engineering. So at the nano engineering, where if we're able to engineer the interface between the hardware of the sensors to the optical nerve to be able to transmit, as you can imagine, that sort of essentially may be one of the Achilles heel of these interfaces where, you know, we may have a bulky, copper wire. How do you make that connection to stay to a nanometer nerve ending, for example, and have it stay connected?
Okay. So another question is, did you practice medicine in Michigan? And where do you practice now?
I'm at Huntington Hospital by Pasadena right now, and I was in Michigan for 7 years, in Pontiac, Michigan. I did not practice. I finished my residency there, then moved to Central California to a little place south of Fresno, between Bakersfield and Fresno. Then I was there for 10 years, and when kids were born and parents here, we moved back to the same place where this whole journey started about 30 years before that, a couple of blocks from Glendale College. So I made a 35-year round trip across the US.
It sounds good. You made the travels worth it, I guess. I think those were it for the questions, unless we get more questions or raise hand. This may conclude our lecture. Thank you, Ara, for your time.
Thank you very much.
Sona?
Yes.
I'm sorry, the chat is unable, so I can't type anything. Just a quick question for Ara. Does vision therapy and exercise help divergence insufficiency in the eye?
In theory, it will. I think it may also depend on the underlying causes. So, as you know, the concept of the vision therapy would be to try to focus the perceptive information to the muscle level to have them directed in intended site, essentially. And so it can, unless there's an underlying congenital retinal issue that's causing the divergence.
All right. Thank you so much.
Thank you.
Okay. Any other questions? Okay,
Um,
looks like
Great. Thank you very much. I apologize for the delay and technical issues that we had earlier today.
All right, thank you, Aura, for everything. I know we're all busy, working at home sometimes, and thanks for dedicating some time to us in this pandemic. And I hope everyone stays safe and indoors until everything is over.
Stay in and stay safe. Yes, please.
All right, thank you very much.
Thank you, sir. Thank you, everyone.
Thank you,
Thank you.
Ara. Bye now. Good night.
Thank you. Good night.
Thank you.
Bye.